second treatment, it was a non-split table. And it was talking about how many pounds to start, how many pounds to end. If we have low back pain, what is the start and ending pounds? Is it the same or different?
The same.
The same. So if you had different pounds, shouldn't have been the case for low back pain, which is an intermittent protocol. So you're going to start at one number, you're going to end at that same number. Okay. So, person weighing 108 pounds, half of that is?
54.
Minus 20 is?
34.
34. 25% of 34 is?
8.5.
8.5 plus 34 is?
42.5.
42.5. So, for your first treatment, you would either be at 42 or 43, because you can round it. All right. And then, will you increase during that session?
No.
No. So the first treatment was 42, 43 to begin. By the end, you're still 42, 43. So you said 42 or 43, whatever, that would have been your thought process for the first treatment. The second treatment, we're going to add about 5 to 10 pounds. All right. If we add 5 pounds, we're looking at about 47, 48 pounds. If we add 10 pounds, we're looking at about 52, 53 pounds. Okay? So I think people may have gotten thrown off in the math part. All right, lecture clear. We have to be real careful when we look at questions that talk about the differences between something. Right? What's the difference between yin and yang? All right, saying female and male is an example. It's not the true difference. What's the true difference? Negative. Something else. Sedative. Energy. Give an example of night and day, cold and hot. Those are examples. But what's the global overall difference? All right. That question was worth 3 points because it says, what's the difference between the two? So you had to talk about yin, you had to talk about yang, and then it talked about how they should, how do they coexist together or whatever, for whatever reason. All right, so make sure we look at the foundational reasons for that. All right, next, let's look at the pelvic traction practical. Just want to hit on a few points on the practical. Page 34. Okay, I'm just hitting a few areas that we really want to be very cautious about. All right, looking at number 2 on page 34. All right, it says ask about reaction from previous treatment or patient's treatment exposure. So, patient's treatment exposure is really talking about have you ever had traction before, especially if this is your first time treating them and this is their first time getting traction. First time getting traction at your facility. But it might not be their first time getting traction, period. Maybe they got it somewhere else, but it's just the first time them getting traction at this facility. All right, so if it's the first time getting traction, period, then give a good explanation. So make sure you give a good explanation as to what traction is going to do. Try not to talk to your fellow student, but try to talk to a patient the way that you would talk to a patient. I am not going to. No, I ain't going to. I'm not going to. I'm not going to. You going to see it? I'm not going to do it. And then, or the previous treatment. The previous treatment. So how was yesterday's treatment? How was that session? How was that time? All right. Okay, now, number 4, inspect skin. Checks range of motion. Now, how can we document improvement?
Going.
So we can't say they bent over a little bit further than the last time. we can't say that. All right, so... So, we want to be mindful of how to measure, because if we want to have some improvement from the beginning to the end, then we want to use the tape measure if we have to use that, or use the goni if we want to use that, but we want to have something that we can document, especially as a PTA. So we want to make sure we get that down. All right, explains treatment, we just talked about that. All right, when it talks about positions for effect for moist heat, checks the skin, I'm not going to say, well, we're not going to do the heat, yes. But you still need to have it in your repertoire as to where it goes. All right, I don't like to tell people what we're not going to do, because then they hurt themselves not practicing that, and then it messes up their flow for the practical. So put it in, and then let us say, okay, you did it. But that way it keeps you flowing in your practical. If we tell you from the very beginning something's not done, then your whole flow is thrown off. Because you know in real life you have to do it. Okay. So, but the main point is just be mindful of how you're going to lay this person down. And if you are the patient, if we don't, for whatever reason, find somebody else to be a patient, if you are a patient as a student, be in pain. Don't. You're in pain. If you play the part, it helps the person to really do better. All right, so make sure you be in pain. And if they're in pain, then help them lay down. Help them lay down. All right. Let's look at number 10. Rechecks patient's position. I would really say even there, rechecks everything. So, or even from the beginning, after we lay this person down, the first thing I would do is I would make sure that if I have a split table, L4, L5 is at the split first. So if they're a little bit too high, scoot them down. All right. L4 is at the split. Then make sure they're in the center. Then I can start tightening belts, putting the towel there for need, tighten that way, do what I need to do. Make sure that the table is low enough for the patient to get on. So don't let them. They're in pain, so put the table down. But if you have a table like this one here, don't get thrown off because of the angle, because then the angle's down here. So once you get finished setting them down here, because you may be a little short, then bring it up at the right angle. All right, so don't forget those little things. Yes?
Number 9 says symmetrically and snugly.
Yeah. Tight, firm. Yeah, so when they say I can't breathe, it's like, good. No, I'm just kidding. You just want it on really good and stuff. And then sometimes what I would do is I would take some of the strap after I put it on and just do it my own little tug to see if it's slipping. So that's the way you'll check to see for sure. All right, I think you go with the dials. 12. Gives the patient the control switch, and then says if you have any key phrase, increase. Not if you have any pain, numbness, or tingling. They probably do have pain, numbness, and tingling. But increase. If you have any increased pain, numbness, and tingling, make sure you let me know. And here's the other big one. Warns about when to turn on. Miss Jones, I'm about to turn the machine on. You're okay? Good. Beep. Press the button. If you end up with the Triton machine, this manufacturer has said you need to press the lumbar key just prior to cutting it on, because it's going to think that, maybe you want to pull the cervical, and it's just want to make sure that you're not pulling the cervical. So press that button there. I think it's the same way on this digital machine over here. Press lumbar, because it's going to come up and not let you do it before you do it. All right. 13, reminds patient about what they would be feeling. Should be feeling a firm pull, Miss Jones, in your low back. All right, so some of this is just talking, explaining. 15, separates the table after the max pull, unless it's static, and then we're going to do before we press start. It's intermittent after the max pull rest cycle. All right. Leaves when all is in order. So physically walk out. All right. If you have a static protocol, talk to the patient in a way that you want us to hear you. All right. So I'll say, Ms. Josephine, what I'll do is I'm going to step out and I want to come back because I want to try to do the counseling. So let me step out and work with the next patient, and I'll be right back. That gives me an insight that I know you're thinking about coming back in order to increase the pounds for this static protocol. And you might go out the door and I'll say, all right, come back. And then we'll see how well you can increase the pounds. If you're doing static on this machine, just turn the knob. If you're doing it on that machine, you pretty much just increase the pounds there. Here it's max level, arrow up, max level. And that's one there. All off the unit, releases the cord gently, closes the table. Now you might have to ask them to bridge up a little bit if you have a split table. You're going to have to ask them to bridge up a little bit and lock the table. And then, as I said before, inspect what you expect. After you thought you locked it, then check it. Just to make sure. Just to make sure. All right, just to check it. All right. So that process of locking the table. Machine off. Lock the table next. Unloosen the belts after that. If you cut the machine off and unloosen the belts and you get to talking, if they get up off that table with the table like this here, they can hurt themselves.
Is that
All right.
machine off?
Off. Beep. Off. Lock. Then let the belts off. Because as long as the belts are in place, they can't go anywhere. But if you unlock the belts and the table is still unlocked, and, you know, it's just like a child. You tell some people don't do something, and they do it anyway. If they get up, they can hurt themselves with that table jiggling back and forth. All right, so we don't want to do that. All right, and then I think we're good with exercise. I think we should know what to do with that. All right. The only thing is with exercise, make sure you're counting so you can get paid. All right, so you should be counting. If it's seconds that you're going to hold, make sure you say that. Make sure they know. Make sure you don't do it too fast. Nice and smooth and easy. But 19, assist the patient from the help them. We're in physical therapy, not physical torture. All right. All right, let's go to the back of the book. Go to 67. All right, now, we are just touching on, we're just brushing on the next book information. So I just threw this checklist in here, one of many.
60.
See what?
7, yeah.
You don't have it.
I got it.
All right. Now, we're getting into a transfers unit because we're working with spinal cord patients. We're working with CVA patients. But what we're going to do today can apply to quite a few patients. All right. So we'll write down a few patients that we could do this particular transfer with. And we're going to go next door and just show that right quick. And just get the jump on the table just to see how we can do that. Now, we're talking about a perpendicular transfer. Perpendicular transfer means you're going to pull up the wheelchair perpendicular to the bed.
We
Oh,
unplugged
yeah,
it. You almost went face first out the window there. That wasn't going to be too swell. Can you wait for the...
All right, so perpendicular. They're pulling up the wheelchair perpendicular to the mat. Sometimes it may be just spacing, maybe a spacing issue. But why is it that they're going to transfer onto the bed this particular way? You may have a bilateral amputee, above knee amputee with no prosthesis. All right, so if I have, nothing here, there's another way we can do it. We'll talk about that too. So we're going to show more than just one type of way to do a transfer. All right, but this is one way. So a bilateral amputee, above knee amputee, they have no prosthesis. So I can't stand up. So how do I get in the bed? All right, so this is one way to do it. All right. If you have a paraplegic patient, what's paraplegic? Halfway.
Paralysis.
Legs. All right, so, the legs are flaccid. So, if I stand up, it's not going to work. Now, we have some transfers we can do, and we'll teach those where they can still do that. But here are just options to do certain things. All right? We're going to teach a whole bunch of types of transfer. Rheumatoid arthritis and bilateral lower extremities, and they have pain with weight bearing. Rheumatoid arthritis bilateral lower extremities, pain on weight bearing. So if I tried to do a stand pivot transfer, oh, that hurts too bad. All right, so I still need to get in this bed somehow. Okay. And then bilateral lower extremity fracture. They was in a car accident and both legs got broke. And they have cast from the ankles up. Both legs. How did they get in the bed?
We did the one in the hospital
Uh-huh.
or bilateral or
At your
had a
clinic?
rupture in the quad tendon. Both.
And they couldn't put weight on that leg. Yeah. All right, let's shoot next door. We'll see how this goes. All right. Yeah, you can bring your book. I'll kind of look at this here. Spinal cord transfer. This is just a transfer for a patient who may need it. All right, but let's say that he does have a spinal cord issue. Most spinal cord patients may just put both feet on the floor and do a transfer over with both their feet on the floor. This is another option. This is just another one. So let's look on page 67. All right. So we would explain the procedure. We get a wheelchair, make sure that's in place. Then we'll have the patient position the chair facing the side of the bed, and we'll be close enough so that his toes will probably be right there at the edge of that chair. All right. Then they'll lock the chair. Lock the chair in place. And it says patient will carefully lift the legs onto the bed. Now, if he's in two casts, then of course he would have leg rests that would already be sitting here, and he would have to lift legs off. All right. So if your legs are flaccid, you can't do this and then the quad just kick in, because this doesn't work. So we have to lift here and lift there to place it onto the bed. So try that. So underneath one, underneath the other, place it on the bed. Then of course he can swing the leg rest away. Then he's going to roll the chair forward. If he's going forward, most of the time, this is when most of the tipping back could occur. So it would be good if he somewhat externally rotates his legs. That way his heels will slide a little bit better on the bed. It would be good for you to be in the back, because as he's rolling forward, he could tip back like this here. All right, so we don't want that to happen. So just kind of guard here in the back and just roll yourself forward. All right, and then lock yourself in place. All right, just give an option. All right. Then it says, has patient push up and move forward in the chair, cueing for head motion and hand placement. All right. So if he's a para and he doesn't have leg function, all right, he will have to push down. And after he pushes down, how do he get the hips forward if they really don't work that well? Momentum. So push and then throw your head back. And if I do this, what happens to my hips automatically? It causes them to go forward. All right? So I want you to push here and push there. Now, we're not doing this. Really throwing that body. Now, let's say that that's the foot of the bed. If that's the foot of the bed, it might be good now to start angling those feet this way. So go ahead and angle. Good. All right. Then we're going to place one hand here and one hand on the bed. All right. Now, again, how does he get over to the left? Well, we know if he wanted to go forward, he had to push down and throw his head back. If he wants to go back, he has to push down and throw his head forward. If he wants to go over to the left, he's going to push up, he's going to duck, and he's going to throw his head to the opposite direction. All right, almost like a little jig. All right, so push up. Yeah, you go. And now he's in the bed. This is just an option. You may not see this with paras, but you may see it with double fractures or whatever. Because it's not a para transfer, it's just a patient transfer, depending on what the condition is. All right. Then coming back. All right, so just go ahead and so, push down. There you go, good. Push and duck. All right, good. And then line, and then don't get on the crack now. Good. You can get on the edge, but don't get on the crack. This would be the most dangerous part of the transfer.
Yeah.
So the most dangerous part is between the table or between the mat and the chair. Because if this chair has bad bricks, or if you didn't lock it or whatever, then he goes right in between. All right. Now, if he wants to go back, if he pulls his leg up like this here, this will help him get a better push-up. All right. So he can pull this leg back here. Some of the friction on the bed will keep it somewhat in place. All right.
So for people who like to stay extended,
Then it's going to be much harder. Okay. So if they need to keep their legs extended, it's going to be much harder. This would help to get a higher push-up. All right. And you're going to put your hands on the chair, and you're going to push and throw your head forward. And then bend this leg again because you want to get a different push. One is just enough. Yeah, one is enough. And then go ahead and you can straighten that back out. Unlock, roll yourself back to the heels. And then lock back in place first. And then go ahead and swing the leg rest back and forth. And then one leg at a time, make sure you place them because they are flat in that. There you go.
so bilateral amputee, right? There above the knee, there is no length.
Right, so in that case, he would have to roll close enough to get the stuff on top and then just roll in place. So you kind of have to work with what you had. And of course, you don't have a foot to help you to get higher for that push-up, so it's going to be a little bit harder depending on how much bottom they have there. So, we got 6 minutes for anybody who want to practice. If you don't, goodbye, see you Monday.